Hello, and welcome to McFarland Clinic's webinar, Understanding Memory Loss, Know the Difference Among MCI, Dementia, and Normal Aging. I'm Shelley Jakey, Marketing and Public Relations Director from McFarland Clinic, and I'm going to serve as your host and your moderator for the webinar today. Thank you for attending. We have three speakers who are experts in healthcare and human services. Dr. Olesya Grinenko, McFarland Clinic Neurologist, Jane Esterly-Rettig, a public health nurse, registered nurse with Story County Public Health and Mary Greeley Medical Center, and Laurie Yocum-Whipple, who's the Director of Adult Daycare Services at Heartland of Story County. These ladies are going to be covering a lot of topics with us here in the next 60 minutes. They will be covering mild cognitive impairment, or MCI, and dementia, how they are diagnosed, common causes of dementia, including Alzheimer's, and treatments available, tips to reduce your risk and support brain health, and helpful resources to support caregivers of individuals living with dementia. Before I introduce our first speaker, I do have a couple of quick housekeeping items for you. The first is regarding questions. As you registered for today's webinar, you had the opportunity to submit some questions, and we thank you for that. We were able to summarize those questions and provide that to our speakers. So we hope that you find that a lot of those are answered throughout the presentation. But please know that you can also submit questions at any point in time during this webinar. For those that are on virtually, there's a Q&A or a question and answer button. Go ahead and click that and type in your questions. I'll be looking for those. We're going to leave some time at the end of the webinar to be able to share those questions back with our panelists. And for those that are out at the 60 Forward building in Ames at the Watch Along Party, you have the opportunity also to submit questions. There's sheets of paper there. You can jot down your question and give it to either Brooke or Jen, and they will relay those questions as well. Today, we are recording this webinar, so anyone who registered for the webinar will receive a link to the recording in your email next week, by midweek at about Wednesday. You should expect that. We also place the recording on McFarland Clinic's website along with the slide deck presentation, so you can view it again, share the links with your family, friends, neighbors, loved ones. And last but not least, we do offer a survey at the end of the webinar. For those that are on virtually, that survey will pop right away. Please take a few minutes. We've got a few quick questions. What were some of your takeaways? What can we do to improve? And what other topics are you interested in learning more about? And for those that are out there at 60 Forward in the watch along room, you have the opportunity as well to complete the survey. When you get back to your computer or your inbox, there will be a link with that survey for you to provide that feedback to us as well. Well, at this time, I would like to introduce our first speaker. I do want to mention that each of our speakers are based out of Ames, but do know that the many services and resources that they offer extend out into greater central Iowa. So Dr. Grinenko, McFarland Clinic Neurologist, is our first speaker. You can see she's got her camera on. Thank you, Doctor, for taking your time and to share your expertise today. And I'm going to turn it over to you to walk us through this important information.
Hello, everyone, and thank you so much for joining us today. And today we will cover what is the difference between mild cognitive impairment and dementia, as well as how normal aging is different. And we'll talk a little bit about the causes and potential treatment options, and we'll also cover how to support brain health. Occasional forgetfulness is the part of normal aging, and we may misplace keys or glasses, but we're usually able to retrace steps and find them later. It's normal to forget names, but then remembering it. And we all need some assistance with new devices. And its irritability when routine is disrupted is also can be normal. Mild cognitive impairment is impairment in memory and thinking that is more than expected for age, but still not enough to disrupt normal daily activities. The signs of it are frequent misplacing items and finding them in odd places. It's forgetting recent events and important information and important dates, asking repetitive questions, and trouble following conversation and avoiding social interactions that can eventually lead to social isolation. So what is the dementia? Dementia is decline in memory and thinking that interferes with daily life. And we usually see this decline, what we call in multiple cognitive domains, which includes memory as which usually short-term memory is affected first. A person would ask the same question multiple times. Language can be affected, and there will be more difficulties with understanding speech as well as expressing themselves. Attention is affected. It's harder to stay on track. Visual spatial skills can be also affected, and person would find more difficult to get oriented even in familiar places. There will be some misjudgment of distance, and at this point driving concerns become important. And also judgment and ability to make decisions can be affected in people even with mild dementia. So I always encounter question, is it normal for me if I have some troubles with my memory? So the reason to talk to you, doctor, would be memory loss that disrupts daily activity, like also repetition of the same questions, getting lost, even in familiar places, some difficulties to manage bills or medications, some changes, significant changes in mood or behavior, and also, very importantly, concerns from friends or family. And it's not necessarily means that you're developing dementia, but there can be multiple causes of it, potentially reversible, and it's important to address it earlier. It's important to understand that cognitive impairment is a continuum between mild cognitive impairment and severe dementia. And knowing where the person is in this continuum helps us to guide our care. So even at the level of mild cognitive impairment, person may need more supervision with medications, finances, appointments. At the level of mild dementia, driving safety becomes major concern, and it should be reevaluated frequently, not just by physicians, but also by family members. What I usually tell that from time to drive with your loved ones. He or she would be a driver, you're a passenger. If you feel safe to drive, that's probably it's safe. If there are any concerns, we should go ahead and do formal driving assessment, prevent major issues. As dementia progresses, the person would need more and more care, including full-time supervision. It brings more burden into caregivers. And later during our webinar, we'll talk about community resources that are available for people with cognitive impairment and their caregivers. So there are multiple causes of dementia. We will not be able to cover all of them during this webinar, and we'll talk about the most common ones, which is Alzheimer's disease. It encounters about 70% of all dementias. Also vascular cognitive impairment, which often goes along with other diseases like Alzheimer's disease or Lewy body disease. Frontotemporal dementia is rare, but a lot of time we encounter mixed dementias when Alzheimer's disease pathology and Lewy body disease coexist, and vascular cognitive impairment can be on top of it. Next slide. So the common question is, is Alzheimer's disease is the same as dementia? Or do I have Alzheimer's disease or do I have a dementia? So it's important to understand the difference. So Alzheimer's disease is a disease that results in progressive brain damage. And dementia is a constellation of symptoms that describe this cognitive impairment. And brain changes in people with Alzheimer's disease starts decades prior to first clinical symptoms. And dementia, what I always say, is end stage of the disease. And next slide. So what's happening during this 20 years or more before first clinical symptoms, before first cognitive impairment become noticeable? There are two abnormal proteins that builds up in our brain. One protein is amyloid that builds up between brain cells and forms plaques and disrupts communication between cells. And the other protein called tau that builds inside brain cells and eventually damages it and causing brain cells death. And when this cognitive impairment with these changes in the brain progress, eventually it would cause cognitive decline. And this symptomatic stage of Alzheimer's disease lasts in about from 7 to 12 years. But for each particular person, it's very hard to predict how fast memory will continue to decline. And when I encounter the question is, okay, how many years I have before I develop severe dementia, I always tell, I don't know, because there are multiple contributing factors that can affect the disease progression. And next slide. Okay, so in this preclinical stage, people may feel that they have memory issues even before we can see any changes in our tests. There may be some mild behavioral impairments, some changes in mood and behavior, but because it's so non-specific, it's almost impossible to diagnose preclinical Alzheimer's disease without specific biomarkers. And we'll talk about these biomarkers later during the talk. Yeah, can go to the next slide. So the other common cause of cognitive impairment is vascular cognitive impairment. What it is reduced blood flow to the brain that can be caused by strokes due to blockage of major brain vessels or by damage of small vessels. That's what we call small vessel disease. And it can give some cognitive decline, but also it coexists with other diseases like Alzheimer's disease and Lewy body dementia. And having this small vessel disease, it increases the risk of conversion of preclinical Alzheimer's disease to clinical syndrome, but it also can worsen severity of dementia. And on the right, there is MRI brain, which shows white matter changes. These white blobs, that's the impairment of the brain that we can see in people with white matter disease. And the good news is that those changes are potentially preventable with appropriate blood pressure control, cholesterol control, diabetes control, as well as avoiding smoking. We can go to the next slide. Okay, so diagnosis of dementia is very complex. We usually start with history from patient, but even more importantly, from family members or friends who know the person the most. We do cognitive testing. We look at lab work. Frequent lab work that we do is checking thyroid, vitamin levels, and we'll always do MRI. And this usually already done at primary care physician office. And when secondary causes ruled out, we can look at more details. What are the other causes of cognitive impairment? And next slide. Okay, so, and there are more specific disease biomarkers which we currently can measure. We can measure phosphorylated tau in blood, and that is very specific and sensitive biomarker of Alzheimer's disease. We can do spinal fluid analysis and measure amyloid and tau in cerebrospinal fluid. It's more invasive, so we don't use it often. We also can do imaging like amyloid PET, which would be diagnostic for Alzheimer's disease. We can look at that scan, which can help us to diagnose Lewy body dementia. And we can do glucose PET, which would help to diagnose frontotemporal dementia. We also now can do skin biopsy to diagnose Lewy body dementia. There's different protein, alpha-synuclein, that builds up in the brain, but we also can see it in the skin. And that's also very sensitive and specific way to confirm the diagnosis of Lewy body dementia. And next slide. Okay, so I often encounter question, okay, I have family members with Alzheimer's disease. Would I develop it? Is it hereditary? It is not in most of the cases. Although having family member with Alzheimer's disease, especially close family member, increases risk of developing dementia later in life. We know there are some genetic predisposition to it, such as ApoE gene increases risk of developing Alzheimer's disease. But a lot of people with this gene would never develop this disease, as well as a lot of people with Alzheimer's disease would not have this ApoE gene. We're still using this test, but more is to assess the risk of treatment rather than to diagnose Alzheimer's disease. And there are also rare mutations that can be seen in people with early onset Alzheimer's disease, but this genetic Alzheimer's disease encounters about 1% of dementia. So most of the time is not directly inherited. And next slide. So in regards of treatment options, I usually start with lifestyle changes, and I feel like it's probably the most effective and effective treatment and the most important. And we'll talk about the lifestyle changes later in much more details, but what it is healthy diet, exercise, control of blood pressure, cholesterol. And that's where you can work with your primary care physician, not just with neurologist. It's important to sit with your doctor and look through medications you're currently taking, because some of them may worsen cognitive performance. Common offenders are sleep aids, pain medicines. So it's important to revise, do you really need them? We can prescribe some what we call memory-enhancing medications like donepezil, rivastigmine, memantine. So they don't change long-term outcome, but they may give some improvement. So basically, people who are taking this medicine are 10 to 20% better compared to people who are not taking these medications. And also there are emerging anti-amyloid therapies. There are two medicines currently available, is donanemab and lecanemab. People who are on these medicines about 30% better compared to people who are not on these medicines. It's still not a cure. Plus, there are a lot of risks associated with this medication. So not everyone would be a candidate for this treatment. And treating what we call comorbidities, so associated depression and anxiety, is also very important part of the treatment. And next slide. I made this slide separately because I encounter very frequent questions. So I was on atorvastatin or any other statin. Did it cause Alzheimer's? Did it cause dementia? Or should I stop statin medicine? There were several studies done that specifically address these questions. And there are no evidence that statins would cause dementia, would cause cognitive decline, Alzheimer's disease. And so basically there is no cognitive harm from statins. And actually they can reduce risk of vascular dementia and potentially actually improve function. It's known that statins decrease the risk of stroke. Okay, next slide. It's very fast developing field, so there are a lot of clinical trials going on. Currently, people are working on another protein called tau to see if we can clear up this protein from the brain and stop Alzheimer's disease progression. There are also non-pharmacologic treatment options like neuromodulation, light therapy, cognitive training. And so if you're really interested in these studies and interested in participating in research, I would suggest look up website clinicaltrials.gov, and you just can put Alzheimer's disease or mild cognitive impairment in your search and look up what are the studies available nearby. Okay, next slide. So more than 50% of dementias are preventable, and that's definitely good news, but we need to start earlier. So one of dementia risk factors is less than 10 years of education, and that should be addressed early in life. In middle life and late life, the major risk factors become excessive alcohol consumption. Depression can increase risk, untreated depression can increase risk of dementia. Vision loss, hearing loss increases risk of dementia. Uncontrolled diabetes, uncontrolled high blood pressure, uncontrolled cholesterol. Also, physical inactivity is increasing risk of dementia, as well as obesity and social isolation. Traumatic brain injury and multiple concussion also increase the risk of dementia. And next slide. And at the end, I want to share with you the fascinating studies that are currently going on that connect our breathing, heartbeats, and brain health. So with every heartbeat and every breath we take can affect our cerebrospinal fluid flow. So it causes this gentle pulsation. And this pulsation can affect our brain cleaning system, which called G-lymphatic system. And this G-lymphatic system, it clears waste from our brain, such as amyloid. And if this dynamic is disrupted between CSF flow, heartbeat, and breathing, it may impair that waste clearing and would cause neurodegeneration. So, and can progress, cause worsening of cognitive impairment. And there are currently several studies are going on. One of these at Mayo Clinic, not too far away, on healthy volunteers. And they are studying how breathing can affect cerebrospinal fluid flow. And hopefully at some point we can translate these studies into people with mild cognitive impairment, and hopefully we can learn the ways how to activate our natural cleaning system and prevent Alzheimer's disease, or maybe even treat Alzheimer's disease, slow down it. And I think it's one of the future directions that we should work on. And next slide. Okay, so that concludes my talk, and Jane will take over and talk more about keys to dementia prevention.
Great. Thank you so much, Dr. Grinenko, for covering all that information. And just a reminder to our participants that you can, for those who are on virtually, submit any questions through the Q&A button. I'm looking and monitoring. We have some of those starting to come in. We'll leave time at the end of the presentation after all three of our speakers. And those that are in the room at 60 Forward, jot down your questions, hand them to Brooke or Jen, and we'll incorporate those as well. So at this time, I would like to introduce Jane Esterly-Rettig, who is a registered nurse with Story County Public Health and Mary Greeley Medical Center. Hello, Jane. I know you've got a lot of information to cover here too about dementia prevention.
Yes, thank you, Shelley. So I am Jane Esterly-Rettig, a nurse at Story County Public Health, and I'm also adjunct faculty for DMAC nursing. And thank you to McFarland for allowing me the opportunity to share about this really wonderful course. So the Keys to Dementia Prevention course was developed by Dr. Patricia Quinlisk, former medical director and state epidemiologist at the Iowa Department of Public Health for 24 years. Brain Help and Hope is the organization that supports this Keys to Dementia Prevention curriculum. So the course is all about prevention, and it is for individuals without any cognitive loss. So the 10-week course meets weekly for 2-hour sessions. Each session covers evidence-based ways to reduce your individual risk of dementia. The goal for participants is to incorporate changes they can sustain for the rest of their lives. So small lifestyle changes are encouraged by participant goal setting, peer support, and facilitator encouragement. As a facilitator of the course, my role is to provide information and present the most current research. The participants guide each session with questions and sharing. We do have content experts present information at some of the courses. Outside of class times, participants also have the opportunity for one-to-one sessions with a dietitian, pharmacist, fitness professional, and goal wellness coach. Dr. Quinlisk continues to ensure the class has positive impact by having participants complete before and after fitness tests and a behavior lifestyle quiz. So the following topics are what we refer to as the keys, and these make up most of the class content. So eating well and moving your body, those are right up top there, are very important, and we'll get into specifics in future slides. So number 3 is being social. Making connections with other humans in meaningful ways is supported by research to decrease dementia risk. So every day, talk with others, find common ground with others, laugh with others. One of the best ways to be social is to volunteer. Number 4 is hearing and seeing well. So both hearing and vision have large impacts on brain health, and research indicates using aids, if necessary, is dementia prevention. Number 5 is staying sharp, and we will discuss this in a future slide. Number 6 is sleeping enough and sleeping well. So sleep has an immediate and long-term impact on our brains. In class, we discuss sleep hygiene and the role sleep plays in dementia risk. Number 7 is managing any chronic conditions you may already have been diagnosed with. For example, if you have diabetes, it's vital that your blood glucose be in good control. If you have high blood pressure, then what do you need to do to keep your blood pressure in a good range? During class, we review research regarding stress and brain health. We all experience stress in our lives, so we explore healthy ways to manage our stress. Mindfulness, meditation, and leisure are all discussed as stress management. Number 9 is the topic of medications. So certain medications have been linked to dementia and overall brain health. A pharmacist comes to class and reviews the most current research related to this topic. She also briefly reviews the numerous supplements with lofty claims and little research to support some of those claims. And then finally, we wrap up the course by discussing how what is good for the body is good for the brain. Promoting body health is promoting brain health and vice versa. So briefly, we'll dig into 3 of the keys a little bit more closely. So during class, a dietitian reviews the research of eating well and improved brain health. The class encourages the MIND diet. This stands for Mediterranean Intervention for Neurodegenerative Delay Diet. Quite a mouthful. So the diet was developed at Rush University and emphasizes whole grains, leafy greens, berries, nuts, olive oil, and oily fish. It discourages saturated fats, processed foods, sugar, and salt. Each week during class, we also sample foods from the MIND diet. Research from Rush University indicates that individuals who follow the MIND diet moderately well lower their Alzheimer's risk by about 35%. Individuals who adhere to the MIND diet rigorously decrease that risk by up to 53%. The next key is to get moving. So the next time you go to the gym or go for a walk, consider that you are not only doing it for your heart and muscles, but for your brain. So our fitness professional highlights the research that moving has on brain health. The good news is that even mild physical activity, like walking, is associated with a decreased risk of cognitive impairment. Research is not consistent in duration, type, or intensity of activity for risk reduction of dementia. So overall, we recommend the CDC guidelines for movement. Research does indicate that vigorous activity, this is activity where your heart rate is increasing, does have risk reduction. Engaging in heart rate increasing activity 1 to 2 times per week can reduce dementia risk 29 to 40%, and engaging in vigorous activity 3 or more times per week can have a 35 to 50% risk reduction. The course encourages moving in a variety of ways. So we talk about walking, strength training, including core work, aerobic or heart rate increasing activity, stretching, and balance practice. Keeping your brain active and challenged is vital for brain health. We must be lifelong learners to keep our brains healthy. Mental engagement and cognitive training improve immediate and delayed recall. Research supports speaking 2 or more languages or learning a language later in life leads to increased cognitive reserve and reduced dementia risk. Research also indicates that learning new, complicated skills is beneficial. So taking a college class and really taking that whole class, writing the papers, taking the tests, or learning to play a musical instrument and continuing to learn new music, those things build cognitive reserve. There's some simple ways you can incorporate brain activity into your daily life. Do a variety of different tasks every day. Learn a new word, then do some long division. Mix it up. Engage in brain stimulation as frequently as you can. Attempt to learn something new every day. Challenge your brain. Push yourself to read a challenging book and then discuss it with a friend. If you play a musical instrument, learn that difficult song you always wanted to play. If you do crosswords, look up unknown words and then incorporate that word into a conversation within the next 24 hours. To review, if you want to there you go. These are the keys to dementia that we cover in the course. A course will begin this Monday, which is full with 15 participants. Another session will be starting later this summer. And this fall, we will be offering a mild cognitive impairment keys course. This course varies from the traditional keys course in that a person with a memory deficit takes the course and is encouraged to participate with a support person. You can look for information about upcoming classes on the Public Health Facebook page, or you can contact me at that email or phone number. So thank you again to McFarland Clinic, and I will turn it over to you, Shelley.
Thank you, Jane, for sharing all that information. And I see a website on there, brainhelpandhope.org. So maybe when we go into some question and answer, I imagine we have some folks that are outside of Story County that are interested in, is there throughout the state perhaps? So we'll take that question on, Jane, as we go into Q&A. At this time, I would like to welcome and introduce Laurie with the Adult Day Center at Heartland of Iowa, which is located in the 60 Forward building. Laurie Yocum-Whipple. So glad that you could join us today, Laurie, and share more about resources that are available for caregivers and the loved ones who may be living with dementia. So I will advance the slide here and turn it over to you. Thank you.
Thank you, Shelley. And thank you for giving me the opportunity to come and share the information that we have here at Heartland and that the ways that we can help people who are experiencing and living with Alzheimer's or any form of dementia in their homes. With the Heartland of Story County, we offer an outreach program and home delivered meals and the Adult Day Center, so we can help connect people through outreach to different services throughout Story County and give them meals in their homes and to be able to allow people to stay at home longer. Our goal at the Adult Day Center is exactly that, to keep people in their homes longer and to support caregivers. And we have the 60 Forward Center. So if you're looking at prevention, there's where we come into place where people can come in and use the exercise equipment, socialize, attend the different classes like the one that Jane was just describing, and the different exercise programs that they have at Heartland. So we are in a partnership with the City of Ames, Parks and Rec, and Mary Greeley Medical Center that helps us provide all the things that we do here at the 60 Forward Center. Next one. And we are here to connect people over the age of 60 with physical activities and social networking and health and nutrition. We do have the bistro here as well that serves wonderful, nutritious meals. And this is to connect. There is a calendar on the website of 60forward.org that you can get into and see what the different activities and programs that are available, and will help you decide or to see what programs you might want to sign up for. And then the Adult Day Center, that's where my expertise comes in. I've been here at Heartland for 25 years, providing services to people who have had to deal with some form of dementia in their families. It could be a spouse, it could be a child, it could be a wide variety of different people in your lives. We all will come across somebody in our lifetime that is dealing with some form of dementia, and we are just another resource. There's a limited number of adult day centers in Iowa, and we are one of about 25. So Story County is very lucky to have that service available. but we can provide medical assistance to our participants that attend. We assist with bathrooming. At some point, the care of one of the people with dementia may be incontinence. It's something that we can deal with here as well, and it assists families in doing that. We can also help with showering and bathing. And that is something that sometimes is just a nice thing to take off the plate for family members, that they don't have to worry about that. And this is what we do every day. And people see us differently, so they're cooperative and allow us to do that and give them a spa day and to pamper them a little bit, which they enjoy. And we provide meals. We're providing a snack, and it also is a social time for our participants. They come in, we serve them coffee and hot chocolate, cider, tea, toast, muffins, just a light snack, but it's a social time that they feel welcome. We can be a coffee group, a school, a men's group, a women's group, whatever we need to be to make it a place that they want to be and want to come back to each time. We also, the companionship, they're meeting new friends, they're seeing familiar faces. In the beginning, it can be very difficult for people to start something new, because the one thing you're going to find with dementia is that routine is so important. So our goal is to get this to be their routine. And when this becomes their routine, then family is able to get the needed break that is so desperately needed for caregivers. It's a hard job to be a caregiver 24/7, and we just get to be a part of that continuum of care here, that this is a place that they can come and to actually remove the dementia from the home and give you a chance to take a break and be away from it. We can go back a little bit, I guess. The activities that we're providing, we are providing large motor skill type of activities, so like horseshoes and beanbag toss and shuffleboard and cornhole. Just it allows them to do some large motor skill activities and keep them moving and exercising. We're exercising a couple times during the day. And then we are also working on cognitive games. So we are making them use their brains a little bit and searching for words and long-term memories, which we want them to be successful. So the goal is to give them things that they can be successful at doing, making the activities meaningful, things that make sense to them. And we work with large group activities with cognitive and large motor skills, and as well as small group activities, working with card games and dice games and puzzles. I know Jane mentioned the puzzles, and this is something that we're doing a lot. It could be word search. It could be we're working on crosswords as a group and giving everybody an opportunity to add to that success of completing the crossword puzzles. We have library books, so it could be that somebody's abilities are limited to just looking at picture books, and that's okay too. We want everybody to make sure that what they're doing here is okay and that they feel welcome being here and in a setting that is safe for them. It is a locked facility. We have a majority of our people with some form of dementia. And on to the next one. If I could give any tips to the caregivers, the one thing, first of all, is that you need to take care of yourself. If your health fails, you will be no good to your family member that is suffering with dementia. So it's very important, and utilizing the Adult Day Center is a way for you to get out and do the things that you need to do to maintain your own health. And then it takes a village to take care of somebody with dementia and to establish those support systems early. And by doing so, you might have somebody in your family that is very willing to do physical cares and help with those types of things, and others that aren't able to, but maybe can deal with financial things. So find the things and don't be afraid to ask for help. It will help in maintaining people in their homes. And always, always, always remember to laugh and to have a sense of humor about things and find humor in everything. Because if you don't laugh, you'll cry. And dementia doesn't rob people of dignity. It's our reaction to them that does that. So our goal is to make everybody continue to have that self-worth. And this is my contact information. So if there's somebody that you know, and it could be some people attend 5 days a week, some people attend 1, 2, 3, 4. It's our hours are 7:30 until 4:30. So a lot of times what we see is people starting with 1 day a week and then they build those days. People don't understand how desperately they need the break until they get it for 1 day, and then they see the benefits of it. So we're here, and the thing is, if it doesn't work, that's okay too. It's worth a try.
All right. Thank you so much, Laurie, for sharing about the resources that are available through Heartland and the Adult Day Center, and resources through 60 Forward as well. And then your many years of experience of serving families and loved ones. Some great tips there and reminders for us. So this is the point in time which we're going to start to share some of the questions that are now coming in through that Q&A or coming in from the group that's meeting live out there at 60 Forward. And I would ask each of the presenters to go ahead and turn your cameras on, and I'm going to I'm trying to kind of group some of these questions together, but we'll try to get through as many as we can. Dr. Grinenko, some of these here at the first are going to probably be more in your area of expertise, some specific questions about who is available to take the p-tau 217 blood test that you referenced. Would a family member or someone with Alzheimer's be eligible? Very specific question about that. And maybe indicate again what that blood test does.
Yeah, that's a very good question. So it's very new biomarker that research studies showed very specific, very sensitive, but we use it only for people with cognitive impairment in what we call appropriate clinical context. It means we first get in a history. We know that, okay, that's a cognitive impairment, slow progressions that can be consistent with Alzheimer's disease, or even early stage of Alzheimer's disease. And then we can use this blood test. We don't use this test for screening because so far we don't know how many people in general population may have this elevated tau. And if you order a test, and then you don't know what to do with the result, you may run into a lot of problems. So far, we have no approval for this test to use as a screening tool, even having family member with Alzheimer's disease. But we can use this test as a tool to confirm the diagnosis that this even mild cognitive impairment due to Alzheimer's disease. And also, it's not that easy to interpret the result because if level is low, then we have less certainty that it's Alzheimer's disease, and we may want additional confirmation, such as imaging study like amyloid PET. So that's a tricky situation. So sometimes primary care physician ask me, can I just order it? So you guys will have all information by the time patient would see you. Potentially, it can help, but also sometimes it can be hard to interpret.
Okay. Another question, maybe along the same line. How is that skin biopsy done? That was a
Okay.
question that came in.
It's just we take out small piece of skin. So we actually start doing it here in our neurology office, and then we just send it for analysis. It's like in-office procedure, really minimal risk. And then we get the results back, and that's very sensitive, especially for Lewy body. That's so far we use it only for Lewy body disease. We don't use it for Alzheimer's. Alzheimer's would be PET scan and blood tests, sometimes cerebrospinal fluid.
Okay. Another question along the lines of the scans. Does insurance typically cover amyloid PET scans?
Yeah, as far as I know, I'm not ordering that many amyloid PET scans, so I don't know how what copay is. Yeah, sometimes they cover it, but then copay is ridiculously high. So what it means is that they cover. But as far as I know, Medicare does cover it. But what we always do, we get prior authorization. You talk to your insurance, ask how much it will actually cost me, and then we can already person may decide, okay, I want to go ahead and go with this scan, or okay, I know it's probably not going to change treatment that much, and then I will not do this amyloid PET scan. So if we talk about these new treatment options, like these anti-amyloid treatments, that would be part of the workup before this treatment is offered. So, and Medicare does cover it in this consequence, like you do the studies to decide if you're eligible for treatment. So.
Another question in regards to this is more perhaps prevention, but any specific supplements or specific vitamins that are recommended to prevent cognitive decline?
So the best recommendation is to get what you would get from the supplements or vitamins is to get it from food. So that's why we really focus on eating well and getting vitamins, minerals from the food that we eat.
Okay. And maybe, Jane, another question here. Is there a list of medications that can lead to dementia? Dr. Grinenko talked about a study on a statin, and I think you mentioned that in the coursework, there is a pharmacist that comes in and talks about medications. Is there some list out there, or how would someone maybe access that outside of any course?
Sure. So as we age, the pharmacist discusses our blood-brain barrier, and as we age, it's easier for medications to impact our brains. And so there is a class of medications called the anticholinergic medications, but every medication you take, your physician, the pharmacist is always looking at risk versus benefit. And so you might be taking a list that may have some brain impact. It might still be the right choice for someone to take that medication because the benefit outweighs the risk. So there's not a hard list that we give people to say, no, these medications will cause dementia. It's not that black and white. There are some medication classes that can impact our brain health, impact our thinking, but it's really all a benefit and risk.
Similar question along those lines, the effects of any anti-anxiety meds in the development of dementia and Alzheimer's. And either you or Dr. Grinenko want to speak to that, or?
Yeah, the evidence that I know that benzodiazepines like clorazepam, clonazepam, Valium, so they can lead to cognitive impairment with long-term use later in life. So some people are using meclizine. It's a vertigo medicine long-term, which is also known to be associated with cognitive impairment with long-term use. So what going through medication list every time you see your primary care physician is super important. And the least medicine, the better it is. Yeah.
I'm going to switch gears here to some quite a few questions coming in from caregivers, individuals caring for those that might be suffering from dementia or further disease states. This one that came in right away, a person indicating that their mother had recently passed, their dad has dementia, and they've chosen not to tell their dad that she passed. Because they just think that it's overwhelming each time that they tell their dad that their mother has passed. The note says someone told us that it's called therapeutic fibbing, but they want to know your thoughts as healthcare professionals on do you tell someone with dementia when there's troubling news or a change in the family? What are your thoughts on that?
My experience, that what we see with our participants and my own personal experience with my own mom, it was easier not to tell them because otherwise they would go through that repeated sadness every single time. And then that was something that families had to deal with. And if they're not asking, then that memory's gone, and diverting attention to a different topic, to something different, that it can be easy and as a very simple thing to just change their direction of what they're thinking to get them off of that subject. But it causes a lot of stress and anxiety for people if they are repeatedly saddened by that information.
Okay. Another question in regards to, does dementia accentuate someone's actual feelings? The experience that they're having is there's kind of no filter for their loved one that maybe has dementia. So is dementia accentuating what they truly believe or how they feel about things? And then kind of second to that is impulsive spending kind of a part of dementia as well?
I can take part about impulsive spending. So that's one of the symptoms. We have different types of dementia, and they do present differently. So Alzheimer's disease, common presentation is short-term memory loss with like other domains affected, not in that situation, but frontotemporal dementia can presents with behavioral changes, including impulsive spending, and it's often misdiagnosed like bipolar disorder, like any psychiatric condition. Before we actually, so a person may have the diagnosis for like 5-10 years as a psychiatric condition, and eventually we do more studies and okay, that's frontotemporal dementia. So it can be part of it.
And the first part of that question, Laurie, I don't know if you want to take that.
The emotions, definitely, we see them change. One significant thing that we see often is anger is used a lot of times in the beginning just as a diversion. If somebody gets angry, people back off and don't question them more. And it always comes with like questioning about in early diagnosis, before diagnosis. I'll give the example of my mom. She would, when I knew there were issues, when I would try to address it, she would get so angry. And the one thing we did, nobody wants to get mom angry, so you back off. And then she's okay. Then she is off on her own and nobody's going to bother her for a while until the next occurrence of something happening. But anger, it makes people back off from them and they don't feel intimidated by questions that they can't answer.
The question, Laurie, here, how to start searching for memory care facilities? How does someone start to determine what's appropriate? And there was another question similar about their mom and their dad maybe at different stages and they're wanting to keep them together, and how to go about all of that search and finding the right combination.
One of the main things that I try to establish with the families in the beginning of people attending the adult day center is to find out what their goal is. Is their goal to keep their family member at home? a lot of people want to age in place and stay at home as long as they can. And I know that that is a possibility that that can happen in using adult day services, in-home care, and in-home hospice care. All those things can make it possible to keep somebody in their home. But it's okay also as a caregiver when a caregiver can admit that I can't do this. A caregiver can always be the best advocate for their family member, but they don't necessarily have to do all the physical cares. So at that point, what my role here is to help them find the different facilities that might be able to help them. And if you're looking in Story County, it's pretty limited. You look at the facilities we have as Green Hills, assisted living, Bickford, Independence Village, I believe. There is a memory care unit at Acura. I believe Nevada also has some memory care, but it's to looking at what their abilities are. If they're an elopement risk, that means that they're definitely going to have to be in a locked facility. And that would indicate memory care. If they're not at that level, if they're not an elopement risk, then they could potentially be in just a long-term care setting or an assisted living setting. So it's finding out what's available, or if you want to go into the Des Moines area as well. Aging Resources would also have a lot of information about the different facilities.
Aging Resources. So is that a website then that people can go to, or
It is, and for Central Iowa, and it would cover all the surrounding counties here in Central Iowa, and they can be a great resource to families looking for some kind of support or what they need to do, and could assist families with looking at finances like elderly waiver, getting on a facility waiver, Medicaid.
Okay, because we do have some folks representing Marshall County that were asking, what are the specific programs there? It sounds like that resource, aging, say that resource again so I get it correct, Laurie.
Aging Resources.
Aging Resources. That may be a resource for anyone
of Iowa,
in Iowa to look up and be able to help with this. Are there support groups for dementia and or specific disease states?
Currently, I think Mary Greeley is trying through Heartland. With Heartland, we're going to look at doing something as a support group. I was doing one out at Green Hills when we were out there for a bit, and I do just a Q&A here every first and second and fourth Monday of the month here at Heartland. And that's just not just for dementia, but for Parkinson's or other types of family caregiving issues. And when you're looking at Parkinson's, you're also looking at a symptom of dementia that goes along with that Parkinsonism.
Okay. Looking back through the questions here, just to make sure we've got quite a few of these, I think, covered. There was a question about is there service and support for those with early onset of dementia? Dr. Grinenko, I'm curious, are we seeing more perhaps of early onset, or are we just able to identify it maybe earlier? But this person specifically wondered if there's services and supports for early onset dementia.
I'm not aware about specific services and support. I think we still it's the same service that Laurie just described us. What is early onset is onset of dementia earlier than 65, usually early even than 60. But we don't have, like Alzheimer's Disease Association can be a good resource to look at. But I don't know in Story County if there are any specific support groups for early onset dementias.
Okay.
I'll touch on that a little bit. My experience is our youngest person that we're serving here in the Adult Day Center is 56. So, and we have seen over the last 10 years a lot more people that have been diagnosed with early onset. So we can provide the services for people under 60 with dementia. And Aging Resources would also, there is a family caregiver grant that is available that is through Aging Resources, and that might be a resource for people under the age of 60 dealing with early onset dementia.
Laurie, a specific question. Are the resources and programming provided at 60 Forward limited to Story County residents?
No, we actually do serve people outside of Story County. We just don't necessarily have the funding so it'd be a private pay situation for people coming in outside of Story County. We run on a sliding fee for people in Story County and supplement that sliding fee with our federal and state funding. For people who pay for privately, we are available for people outside of Story County, and we have served people in Marshall County, Boone County, Hardin County.
Okay, very good. I think, I guess maybe one more, and maybe this is a specific one here, Dr. Grinenko, but cognitive impairment, which type of cognitive impairment is most common with Parkinson's disease?
With which type? Yeah. So that's actually Parkinson's disease. It depends what type of Parkinson's disease, because it's always it's often a continuum between kind of Lewy body dementia and Parkinson's disease. So the way we diagnose it, okay, if cognitive impairment started before Parkinsonism, that's probably Lewy body disease, Lewy body dementia. If a person initially had Parkinsonism and then developed cognitive impairment later on within like 2 or 3 years, that's probably Parkinson's disease with dementia. So it's also multiple cognitive domains are affected. Specific to it is people often have hallucinations, visual hallucinations or auditory hallucinations. They may have more fluctuations through the day. So there are good days, bad days. Sometimes they're completely clear. Sometimes they're more confused. And I like memory enhancing medicines that I mentioned before, like donepezil, rivastigmine. So they approved for Alzheimer's disease, but they actually work better for people with Lewy body dementia and Parkinson's dementia. So it just sometimes it helps with hallucinations, gives more good days, the way I describe it. So, but in terms of, what cognitive domains affected more, visual spatial orientation probably affected more in Parkinson's disease and Lewy body compared to memory impairment in Alzheimer's disease. So we can sort it out based on clinical presentation. Now it's much easier because we have biomarkers, right? So we don't bother ourselves that much to separate them clinically. But yes, those are specific features, is more visual spatial orientation difficulties. Hallucinations could be more fluctuation of consciousness, like level of cognitive impairment, good days, bad days. So those are.
Okay. Well, very good. I know we've went past the 60-minute mark, but a lot of great questions there, and really appreciate all the expertise and information our speakers have shared today as a part of the McFarland webinar. Just a reminder, as we close out the webinar, for those that are on virtually, there will be a brief survey. We would love to hear your feedback. And for those that are in the room at 60 Forward, know that in your email, in your inbox, there will be a link to that survey as well. So thanks again to our speakers, and thank you for attending this webinar today. Have a great day.